Hello and welcome everybody to our webinar from Ortho NorCal, your primary orthopedic and spine provider of the South Bay area. My name is Leah Rutinov, Marketing Coordinator of Ortho NorCal, and I'm honored at hosting this event together with Dr. Cornelis Postra and Dr. Robert Cago, both orthopedic surgeons within our practice. Before we begin, a few housekeeping rules. Please mute your microphone as well as your video as a participant so the presentations you are about to hear are better. Additionally, when you look at the bottom of your screen, you will see a small Q&A button that you can click on to direct your question to all panelists. Those will be directed to the surgeons during the question and answer session at the end of each presentation. The presentation that each surgeon has prepared specifically for today is geared primarily towards patients and intended for patient education. We hope you understand that it is impossible to answer specific questions about one single patient situation. So if you have detailed questions, we would encourage you to make an appointment and come into clinic or be seen via telehealth appointment. We would also appreciate that you understand that this webinar is not specifically intended for physician education, and we have tried to keep most medical jargon out of it. Lastly, if you have any additional questions, please email us at marketing@orthonorcal.com or call 408-412-8100 extension 8158. Once again, it's marketing@orthonorcal.com or phone number 408-412-8100 extension 8158. With all that being said, I'd like to welcome our first panelist, Dr. Cornelis Postra. Dr. Postra, welcome.
Thank you so much. I'm very excited to be here and very thankful for the opportunity within Ortho NorCal and of course for all the participants this afternoon. It says now that I'm muted, so maybe you want to unmute me?
No, you're not. You're good.
Okay, very good. So again, I'm very appreciative for everybody's here at 2 o'clock this afternoon, and hopefully me and my colleague, Dr. Cago, will be able to educate you about things that a lot of people struggle with, and that's the sort of degenerative hip and spine disease, and is it my hip or is it my back? So I'm excited. Thank you, Leah.
Yeah, you're welcome.
Okay, so without further ado, I think we should get started. We'll try to keep it to about 20 minutes or so, and then there will be time for questions after my talk for about 5 minutes. And please use the bubble either on the top or the bottom of your screen to type in the question and direct it to Leah, L-I-A, so it doesn't go to all the participants and it's easy for her to sort through it. And then hopefully we have a few questions, and then Dr. Cago will take over, and he will speak primarily about the degenerative hip problems that give you hip pain, and I will address spine disease. And we are both very well versed in robotics, and we really feel that this is the next frontier which we can use to make our patients better with less comorbidities or disease from the surgery, quicker recovery, less blood loss, and earlier time to work and play compared to traditional techniques. So that's what we're going to talk about. So my personal history real quick. I have a bit of an accent, so you can hear that I'm from the Netherlands. I know there's a lot of Dutch people in the Silicon Valley area. Northern Europe, you can see it there. And after I finished medical school, I did a PhD in biomedical engineering, so I have a strong interest in the engineering part of robotics. I did orthopedic residency at the University of Virginia in Charlottesville, and then did neurosurgery and orthopedic spine in Philadelphia at a place called the Rothman Institute. It's the primary provider of orthopedic and spine care all across the East Coast. I think they have about 36 locations now in the greater Philadelphia area. Then I dribbled south a little bit to shock trauma, and some of you guys may have seen the pink scrubs and the TV show from Discovery. So I was in Baltimore for 4 years in sort of a madhouse. And then for the next almost 10 years, went to Sacred Heart Hospital on the Emerald Coast in Destin, Florida, to the beach. We built a hospital that was newly set up there into a top 100 hospital, which is very difficult to do. For people that don't know the Destin area, it is sort of in the western part of Florida, northwest. It's about a 10, 12-hour drive from Miami or so, all the way in the south there. We set up a complex spine center there based on my traditional academic training. Did a lot of good for the community there because it was truly academic spine in a private practice model. And then I joined Ortho NorCal to bring sort of a similar type of academic flair to a private practice setting where there's a little bit more attention maybe to the patients, the surgeon, him or herself takes care of your problem. And although education is hugely important, sometimes having a lot of medical students and residents and so on involved is sometimes not advantageous. So the types of surgeries that I do though in private practice setting is massively complex surgery. Of course, I do a lot of small cases, but we don't shy away from what I used to say is cutting people in half and putting them back together if folks are terribly bent out of shape and we need to get them upright. But the most important thing is to do a patient-centered approach, which Dr. Kegel and I both very much agree on, to ensure you have the diagnosis right. That's what it starts with. And we know about this hip and spine pain thing that is very prevalent. When you're over 60 and you sort of approach Medicare age, 15 to 20% of people have hip and spine pain in conjunction. And we also know that the sedentary lifestyle is progressively making this worse. Because if you're active, there's a 30 to 40% less chance of having arthritic hip pain, despite having on the radiographs, right, on the X-ray, significant destruction of your joint. Also, asymptomatic patients, if you put them in an MRI scan, more than 50% of them have quite significant abnormalities already. So it means that there are maybe things on scans and X-rays that are just a part of normal aging, like gray hair and wrinkles, and they don't necessarily have to be associated with your back or your hip hurting. And a couple of these things are disc bulging. It's a normal phenomenon. About 50% of people have disc herniations without even knowing about it. That can lead to nerve compression, even without having any symptoms. And then there is something that's called stenosis, and that's a very common that is sort of the tightness in the spinal canal. And a lot of people have that on the MRI scan, but might not have symptoms from it. So the goal for us is always not necessarily to make your picture look better, but to make you better and try ultimately to stay away from an operation. I want you to understand that really well. So what we have to do is when we see a patient, differentiate between pain in this hip and back area that comes from the side. We call it lateral hip pain. There's also something we call posterior hip pain, sort of at the base of the back. And then there's anterior or pain in the front, as well as groin pain. So those are the things that we look for when we have a patient who comes in with this sort of hip and back pain kind of thing. We always perform a detailed exam, and then we develop something we call a differential diagnosis, meaning we look at all the different things that it could be based on the type of pain you describe, the location that we identify, and then the exam findings before we even get any imaging. Because that first part there, what I discussed, is often overlooked and very important to figure out what is going on with the patient. So if we look at anterior hip pain or groin pain, we usually consider hip pathology because the hip joint, you see the femoral head there, that round ball, if it is arthritic and it rubs against the cup, that is the opposing end there of the pelvis, it usually gives people pain in the groin, and it gives them a different walking cadence. The way that you move forward, your gait pattern is different, and sometimes the position of the hip and the pelvis while you walk is different, and that's what we look for. And then we check, of course, range of motion, pain location, and strength, and Dr. Kegel will go into all of this. And lateral hip pain, or pain sort of on the side at the top part of your femur bone, of your thigh bone there, can give you a gait disturbance in a way that we call this a Trendelenburg gait. You start to sort of sag on one side because the side that is hurting on that picture there on the right side is not allowing the muscle that keeps your spine upright when you stand on one leg, does not allow that muscle to work very well. And then your hip sort of falls sideways and people start to walk with a limp. And then if the pain comes from the side in an area we call iliotibial band, that's that white area there that goes from the rim of the pelvis at the top all the way down to your knee, there's sometimes a very painful spot over what we call a trochanteric bursa. And this is called trochanteric pain, makes people very difficult to sleep on that side. They get bursitis, which is like a fluid-filled sandwich baggie that's between the muscle and the bone to allow things to smoothly move back and forth. And if that gets inflamed, it can be very, very painful. And then we get to the posterior hip pain, or sort of the buttock pain, that typically makes me a little bit more excited. And it usually means that this is coming from the back. Sometimes it has to do with what we call the SI joint, the sacroiliac joint, which is a junction between your pelvis. You see your iliac iliac wing there, where the arrow is pointing here, and the junction with your sacrum, part of the bottom part of your spine here, that can be the source. But most often it's actually from the lumbar spine itself, and degenerative disc disease can play a role. You see a healthy disc here at the top, and then it thins out a little bit. There's bone spurs that start to form, and eventually the disc can collapse completely. And when the disc height goes down here, as you can see, also the space in the nerve tunnel where the ceiling and the floor have come together, that space is limited, and then sometimes people develop radiating pain or sciatica from the back due to the degeneration into their buttock area and into their thigh. Then there's something that we call facet arthritis. There's little joints in your back that allow your spine to move. And sometimes they get very arthritic, and especially if you try to stand up straight and it's really, really painful, but it's much better when you lean forward. Most often these joints are involved in pain generation. And then the spinal stenosis, or that tightness we spoke about earlier, is a very common thing due to aging, some bone spurs, and sometimes some genetic predisposition also. This is an MRI scan where you can see this white fluid band here with the nerves inside of it behind all the vertebral body and the discs. And if you look carefully here in this red area, you can clearly see that there is a lot of tightness. It's almost like sort of an hourglass where things are squeezed together. And that's the typical stenosis and nerve compression that can give people a lot of difficulty. And then worst comes to worst, this can then also be associated with spinal instability or spinal deformity, like further degeneration in a typically asymmetric fashion. And then people usually end up with the need for an operation. So to give you an idea what that looks like, this is a side view with a normal spine. And then in this area here where the arrow is pointing, you can see that the spine is almost like slipped forward, and that the disc here is gone, and that there is instability here where that line that should be nice and flat and straight is broken and the spine is slipped forward. We call that a spondylolisthesis or a slip. And it can be forward, as you can see with that arrow, or a little higher up on that right-sided image, you can see it can even be backwards. And this can be very painful when you move from a sedentary position to standing, or you go in the morning from laying down to a standing position. Your spine needs to be, with gravity, sort of fit back into the normal location. Here you can see also, if you carefully look again at this similar image, this patient already had identified stenosis, but now, long and behold, there's also some instability. And you can imagine that these nerves that are squeezed and then rocked back and forth are not happy. Sometimes we see worse deformities, and we call them scoliosis. So comparing the two pictures here, the left is normal, the right-sided picture is a adult deformity type procedure we operate on for a lot. And you can imagine that at the inside of the curve there, where all the nerves are coming out, there's a lot of squeezing simply because there is asymmetry in the spine, and that can lead to lower back pain. And this is one of the curves where in an adolescent person, we sometimes have to operate for an idiopathic or unknown origin scoliosis. And some of you might be familiar with this. So what do we actually do once we evaluate all this and we look at these pictures? First of all, we pride ourselves in taking really good care and take really good personal care of our patients with small as well as large spine problems. And we do that mostly through conservative care. So there's a lot of options with therapy. We pride ourselves with the 49ers Fit accommodation for physical therapy to take really good care of this. And this conservative care doesn't just stop with physical therapy and exercise, but also sometimes lifestyle changes, increased walking and weight loss plays a role here. Injections and medicinal management can happen also, and we have a very good ability to perform that in our office. But then sometimes, if all else fails, alternatives need to be considered. And then we're really good also at not just, again, cutting people in half and putting them back together, but to do many small surgeries through little poke holes with scopes to get disc herniations away. We make really small incisions, and everything is geared towards what we call minimally invasive surgery, right? We don't want to hurt you with our operation, but we still want to give you a home run reconstruction, but what will get you back upright. So if the spine truly needs to be reconstructed, that's exactly when robots come in. So despite all these small things, we're going to gear towards like the larger types operation that we would do. And now with the help from the robot, it gives us much greater accuracy, reproducibility, and precision in the operating room. And it makes us really much better surgeons than what we used to be. So because of us all feeling very strongly about this, together with my partners within Ortho NorCal, as you see at the bottom, we coined this thing called the Robotic Spine Institute of Silicon Valley. The next generation of robots is definitely going to be developed in this area as one of the reasons I came here. And I'm very proud, together with my partners, to deliver phenomenal care geared towards hurting the patient less while giving you this home run care. Because everybody agrees with us, right? That when we do an operation, the shorter you're in the operating room or the OR, it's better. We want to reduce radiation in the operating room, and we want greater accuracy and reproducibility. We don't want complications. Fewer is better. We don't want to have to reoperate on you 2, 3, 4 years from now after you have maybe a fusion, right, with rods and screws. And because of predictably planning our surgeries, we've shown that this is so much better for patient outcome. Robotics has really allowed us to accomplish that successfully, and I want to take you by the hand and show you a little glimpse of this. So if you look around us, right, the current state of affairs is that everybody pretty much uses robots. Our military friends protecting us with these things, the cars you drive have been put together by these wonderful machines. And recently I was in China, and this is an Electrolux air conditioning factory, and they used to make 3 million air conditioning units a year with 3,000 people, but now they can do it in the facility right next door to 4 people only. And again, I'm not here to replace people, right? I don't think that that's the motto of what I'm talking about. But we can't close our eyes for what's going on in the world around us. And this greater predictability, this greater accuracy is key for us to take better care of our patients. And if you want to have a coffee nowadays, right, you have all these robotic cafes. Even at San Jose Airport, there's one. And I think the world is onto something, and we should not close our eyes for this. So I was very fortunate to automate a large part of minimally invasive spine surgery for a long time already. Robotics is really bridging the gap with what we did already with patients with less invasive surgery, now to automate it and reduce radiation. And we are transforming spine surgery while doing this with this minimal fluoroscopy or radiation type thing, and maximize efficiency of your reconstruction. And the best thing is that we reduce outliers. These things you don't want. You don't want me to operate at 2 in the morning on Friday when we've had a very, very busy week already, and my hands might not be just as good as they were on Monday morning at 7 a.m. And the robot helps me to continue to achieve this professional precision and not hurt you in the process. So my transformation started a long time ago. I have done more robotic spine surgery than anybody else on the planet. I've developed a lot of different techniques for robots that are being utilized all over the world now. And I pride myself of having really shown that this is better for patients with a bunch of research we have been able to do. So this planning and execution with the robot is really our go-to approach for any kind of reconstructive surgery, since we have shown that it's better than doing it freehand, so to speak, what we used to do. I would not want my mom, for example, to have an operation without the robot, because we've shown that it's better with the robot, so why deny it also to my patients? So the robot I'm going to talk to you about for the next 10 minutes is called the Mazor X, or the Mazor X Stealth Edition. There is a working station on the left there that allows us to plan surgery. Then there is a true robotic arm attached to the patient and the patient table in the operating room. And then there is an ability to view what we do with our surgery through a camera with infrared and special instrumentation. And the way that this works, we plan our entire case based on a preoperative CT scan. You can see the scan there on the left side. Then we identify the area we're going to operate on. And then the robot actually cuts the spine in slices by taking every single vertebral body by itself. That vertebral body then gets presented to us in a picture that you can see right here. So this is a slice, basically, like we take the spine as if it's a loaf of bread, cut slices through there. We get that image on the right-hand side. And that image allows us then to virtually place all of our hardware and build the entire construct. So I'm taking that picture there. You can see in this video that I can move my screws around. I can position them exactly where I want them to be. After I'm done with the individual screws, I am allowing the robot to build a whole construct from one screw to the next, to the next, to the next. So I'm basically virtually completing your entire surgery before I've even touched you. We looked at the way for the robot to get into the spine. So you see those yellow bands there on the right-sided picture. They show what the robot needs to do to get down to the bone and put the screws in there with our help. and we can identify where the skin incisions are going to be. And then eventually we can actually, in 3D, completely reconstruct your spine by placing cages and doing different cuts in the bone to get deformities corrected, and have all of that done even before we set foot in the operating room. Once we're in the operating room, we attach the robot to the bed, which you can see on the left-hand side with my patient laying there. I would be standing on this side of the bed, and I'm going to show you a little video that's taken from the opposite side of the bed to actually show you what we do during the surgery. There's a couple things attached to the robot that allow us to work with it and through it. Of course, it's steered through a screen and touch screen and all that. And most importantly, the robot is attached to the patient. So the coordinate system, for people that know something about robotics, they need to understand it's directly connected to the patient. So the patient is one in this coordinate system with the robot. So how does this actually work? This is a short 4-minute video that will show you what we do during the procedures. We call it like Robotics 101. So this is again that robot, and you see the robot arm there attached onto the table that my patient would be laying on, similar to the picture you can see here. I would be standing on this side, and the patient had a video taken from the opposite side. So we talked about it, that here the robot is attached. I'm standing there and I'm attaching the robot itself to the patient. Then subsequently, there is a drape placed on the patient, which you can see at the bottom. And the robot, in a little sped up scenario here, is taking a couple pictures to make sure it knows exactly where the patient's skin is. Because the last thing I want to do is operate on you and have the robot arm potentially touch you, scrape over your skin, or what have you. So we don't want the patient to get hurt. And because of the scan that gets made here, as you can see, we are staying away with that robot arm from anything below that drape. Then I'm going to tell the robot, you know what, we're going to operate in this approximate area, because what the robot still doesn't know is where the spine is in my patient, right? It knows where the skin is, but I'm now going to help the robot understand where the spine is. So we take 2 x-rays. The robot arm here is holding a what we call fiducial. It has a bunch of little beads in it that are made out of metal. Then we take 2 pictures, and those pictures are superimposing those beads over the spine. So I took my first picture here, then the robot arm is going to move and it's going to hold its arm in the position where my second image needs to be acquired. So I know exactly what the robot wants to see here to give me a good picture of the spine in the operating room. I move my x-ray machine there, and I'm just taking a spot view. So in the past, it took like 4 minutes or so to get x-rays done. Now it takes like 4 seconds maybe. What I then do based on that CT scan, I'm overlaying these pictures with those beads, as you can see, onto that CT scan upon which I have planned my surgery, and it gets matched by the robot in a perfect fashion. I'm then allowing the robot here to confirm that indeed what the robot thought was a match was indeed a perfect match, also upon my visual acumen. So I'm looking here, it's flashing back and forth, and I'm saying, you know what, it's perfect, so I have no concerns proceeding with the surgery. Sometimes I make some small modifications based on where the skin incisions would land here, where you see all those dots, and then we're going to do some surgery. So I thought it was nice maybe if you see me just fire 2 trajectories here. So this happens to be a case we did a while back at 623. So this whole process you just saw, from me putting the robot on the field to operating, takes about 6 minutes. We numb up the skin so you have less pain from the incision that gets made here. I hope people don't get nauseated from this. If you want to look away, please do. But we make an incision in the skin, obviously, and then we put a very thin probe through there, and I'm feeling with my left hand constantly what's going on underneath the skin. We put a little drill guide in there that prevents any kind of skiving, if you will, on like slanted surfaces. And then I'm going to take my drill and I'm going to drill a 30 millimeter, or it's about 1.25 inches or so, depth hole through the area where eventually I want to place a screw. So I'm sort of feeling this, and this is still a tactile operation. Then there's a tiny tube that gets placed in there, the size of the drill bit, and I put a wire in there. Then the tube comes out, and I'm bending the wire out of the way, so I'm ready for my next level. So I can tell it used to take us about 10 minutes and a lot of dissection, and now it takes 40 seconds to accomplish exactly the same thing with much greater accuracy and predictability. So we'll do it one more time here. You see me pass that probe. I'm feeling down towards the surface. Then I'm placing my drill guide. I tap the drill guide onto the bone. I take my drill again, and I'm drilling just a 30 millimeter hole with a stop, so I will never be able to hurt your anatomy. We put that similar tube back in there that can guide my little wire, and the robot moves to the next level. So I put my wire in there, and literally in 40 seconds each, I put the wires. And eventually these wires can be used for cannulated screws to be placed. So we always verify, of course. So the wires are bent out of the way. I verify where these wires are. And of course, from tactile feedback and doing this thousands of times, we know that things are right versus when they feel different than it should be. And then we advance the screws smoothly over the wires, and it's really a much less stressful scenario, not just for me, but for everybody else in the operating room. So we become so much better at doing the essential things of surgery right, because the instrumentation, all this stuff we're doing, has been taken away from us. So far we've done about 7,500 screws, and we're still sort of counting on all of this. And then, as I said, right, we can put screws over those wires, and we follow on an image exactly what the screws look like compared to the plan, and that's what you can see on the left-hand side there. The reason I believe so strongly this works is that early on, when we had our skepticism about this, right, we did a very extensive research study on the first 705 patients. And I don't want to belabor this with all kinds of numbers, and some of you might be more statistically inclined than others. But I can tell you that if you look at that yellow box, when we compared how we used to do surgery minimally invasively, FH stands for free minimally invasive surgery, what we used to do. If we use the robot compared to that other technique, we had a 3-fold lesser complication rate for surgery, and the revision rate at 2 years was almost 4-fold less when the robot was involved compared to our traditional freehand MIS technique, which at that point was a lot better already than the freehand open technique. So based on that data of 700 patients together with my colleagues, we saw fewer complications and revisions, and we had similar OR time. So we were not even slower in that first batch, and we've only sped this up tremendously over the years. And we had about an 80% amount of radiation reduction. So less radiation for you, faster OR time, less revisions, and less complications. So there's no reason really not to utilize the robot. And this is just a very quick picture of a patient on the left-hand side there who's leaning forward without any space in the discs between the bones. You see my plan. Then we plan how we're going to open up the spine towards the right. So I do all this virtually already. And then once we get into the operating room, and the type of surgery doesn't really matter, but we get cages in there, we reconstruct the spine, and we basically restack the patient's spine into a much more upright position, and not infrequently grow patients about an inch to an inch and a half from this type of surgery. They can stand up straight again, their nerve compression is gone, and overall they have a much better quality of life. So that's in short the robot. If we truly work towards the next best thing, how great would it be that we can actually follow this with our own eyes? So this is just a glimpse of me wearing a headset with a retina display that is projecting into my eyeball what is going on underneath the skin. And we are literally able to do this at this point freehand, but the robot is attached to this also. And look what I'm seeing when I look through the skin. It is truly like X-ray vision, but with even greater precision than how we used to take X-rays. And we're able to do these types of surgeries now with much greater accuracy and precision. It gives me greater comfort that I'm treating you appropriately, as opposed to sort of hoping that if the case is done, that we're doing the right thing for you. So looking at this, right, this navigation type technology and robotics will give us greater safety. It gives us greater accuracy and reproducibility of your surgery, and it reduces complication and radiation, as well as this revision thing down the road. So if we look at robotics and the way that it has made entry in our operating room, we are much more efficient and better equipped to take care of you. The economics for the system actually work out too. Although it's expensive initially to acquire, the reduction in complications and readmissions is tremendous. And ultimately, why do we do this, right? Not to be cool and sexy with these robots, but we do it to improve the outcomes of patients while delivering sometimes really very complex surgeries. So embrace this, I think, and us as surgeons collaborating, utilizing minimally invasive surgery and automation and robotics will truly redefine the standard of spine surgery beyond even what I was trained 15 years ago or so to do, because there's a lot of advancements that are in the pipeline. And I'm very proud to say that, together with my partners, Dr. Sigo, Kano, Gitvani, Ko, and myself, we're really on the forefront of this at Ortho NorCal, and we have this Robotic Spine Institute that is allowing you to have this available right here in town at Ortho NorCal. And I would be very excited to have you come in, evaluate things, and explain more. And of course, I'm happy to take a few questions if we should have the time, Leah. Thank you so much for your attention and your time today.
Thank you, Dr. Polstra. We're now accepting questions. If you have any, if you hover your button to the bottom of your screen, you'll see Q&A button. Click on it and the questions will be directed to the panelists. Again, we're now accepting questions.
I actually, I just got a question from somebody who said, if I have a disc herniation, am I a candidate for robotic surgery? Somehow that came to me here. So let me just answer that. So a disc herniation is an operation, once conservative treatment fails, of course, that is currently being worked on. So that's an excellent question, because it's a very common problem, right, that people need to have that procedure performed. And the robots right now are doing what we call targeting of the anatomy. So the robot can target the disc herniation, but robotically we are not allowed from the FDA to equip the robot with little graspers and so on for the robot to start taking things away. So the robot can certainly target the problem very, very precisely. So we only have to make a very small incision and go directly down to your pathology and then take it out. But that is still a manual procedure.
Thank you, Dr. Polstrom. I have another question here from Rich Anderson. Do you use robot for revision spine surgery?
Yeah, that's a great question. Revision spine surgery is yet so much more difficult, right? Because sometimes we have to add on to old hardware and we have to take a lot of scar into account. So the robot makes especially those kinds of cases, I don't want to say easy, but it makes it a lot safer and a lot more predictable, because revision cases very much depend on predictable planning before surgery. And with the robot, we're capable of doing that. And that allows us then to have a much more successful case with much less soft tissue destruction and bleeding. And ultimately, the infection risk we were able to bring down from 1 in 100 to actually 1 in 1,300 cases. So it was a 13-fold reduction in infections in these revision cases by utilizing the robot, and the robot not itself, right, but just being better prepared for the surgery and being much better and predictable in the execution.
Thank you, Dr. Polstrom. One more question. On a Maser X or Stealth, does it give live feedback of the patient's sagittal alignment?
Oh, that's a fantastic question from an advanced user, I guess. So the sagittal alignment can be dialed in beforehand. And now with the navigation component that is associated with the Mazor X, right, this robot we've been talking about, you can actually re-register your spine after you have executed it the way that you had planned it with the robot. And then it shows you afterwards on the screen if you were able to achieve the amount of what we call lordosis, like upright posture, or the amount of scoliosis correction you had in mind, if you achieve that. And that's a re-registration process. So you're absolutely correct. So before you leave the operating room, before you have like standing x-rays and so on, you can get a really good idea if you were able to achieve what you set out to get out of the case.
Thank you. A lot of participants are asking if the video recording will be available for this webinar. Yes, after the webinar is over, the link to the video will be available on our website. That's www.orthonorcal.com. Under news, you can view the webinar at any time. So thanks for asking. Great question as well.
Yeah, so let's get Dr. Kegel out of the gate. Otherwise, we might not have enough time. I'm sorry I ran over a little bit.
Thank you so much. Dr. Kegel, welcome.
Thank you, thank you. Glad to be here. All right, let me pull up my presentation here. Share screen. All right, Leah, can you see it? Everything
Yes,
functioning correctly?
great. Yes, thank you.
All right, perfect. Well, again, I'd like to echo what Dr. Polstra had just said. I thank everyone for joining on the webinar today to learn more about spine and hip pathology. He's a great colleague of mine, and we kind of joke together that, you know, he's kind of the expert on the back of the hip pain, and I'm more the expert on the front or the groin side of the hip pain. So just a little bit about me. I originally am from the Midwest. I got my undergraduate degree in biology at Purdue University, followed by Indiana University for my medical doctorate. Did my surgical training at the Cleveland Clinic Foundation in Cleveland, Ohio, and then did a hip preservation slash sports medicine fellowship in Indianapolis, and then also a trauma fellowship in Bern. And currently I have 3 places that I operate on a regular basis at El Camino Los Gatos, Good Samaritan in Los Gatos, and then the Fremont Surgical Center, where we specialize in robotic joint replacement surgery in an outpatient setting. And on a personal note, like I said, my expertise since I've moved to California here has been on minimally invasive total joint replacement, focusing on the direct anterior hip replacement with robotic assistance, and as well outside of this talk, but also with knee replacement as well. I also have a special interest in revision joint replacement of both the hip, knee, and shoulder, as well as a hip preservation care, which is a little outside of the degenerative hip, more for avascular necrosis or other, you know, non-degenerative conditions, as well as general fracture care. And personal interests, I love spending time with my family, as you can see there. Luckily, we're just blessed in this very difficult time with the coronavirus and a new baby girl. And then I'll also have another big interest in, you know, staying fit with doing, you know, Ironman triathlons. But to kind of get down to it, on the front side of the hip, just some background. It's very, very prevalent in the United States. It's a leading cause of disability amongst patients over the age of 65. And just over 20%, or 1 in 5 patients in the United States, will be diagnosed with osteoarthritis in their future. How is osteoarthritis diagnosed? Number one, as Dr. Polster mentioned, the first thing we always focus on is a detailed history and then physical examination of the patient. Even with all the interesting things we talk about with robotics and CT scans and MRIs, it's still the bread and butter of what we do is by talking to the patient and actually examining the patient. After that, we get x-rays, CT scans and MRI scans, and in some occasions, laboratory testing. How does joint pain in your hip or knee, or throughout your body for that matter, commonly manifest? Well, the symptoms that you chronically see are, you know, just aches and pains throughout the body with daily activities. You know, sometimes you can have heat and swelling around the joint. You can have stiffness or locking of the joints. And one of the most common things I hear in clinic is, I can't sleep at night. It hurts when I roll over. I wake up several times just to move around. What contributes to arthritis? Well, age is probably the number one you think about, but it's actually a lot of genetics and weight. And activities play in, especially if you've had previous injuries to the joint. Some abnormalities you can be born with or then secondarily acquired. Severe injuries over, you know, a single event, or multiple injuries that aren't as severe over a prolonged period of time. And what are the ramifications of that? Well, depression. A lot of people forget that this is a big drain on your life, and it manifests not only in physical pain, but also in mental pain and fear. Now, just to kind of briefly talk about it, not everyone who has arthritis needs to have an operation. Just want to make sure that everyone understands that is a big misconception, that just because you get diagnosed with arthritis, that you are doomed to have surgery. That is not the case in my practice, and I believe with Dr. Polster as well. We believe that, you know, plan A should be non-surgical care. And when non-surgical care fails, that's when you start discussing surgical options. Non-surgical care, you know, typically revolves around weight loss and exercise. I can't overstate that enough. The worst thing you can do with an arthritic joint is become, you know, a couch potato and let your body, you know, waste away with deconditioning and getting more and more stiff. We've learned the hard way that typically a arthritic joint that is continuing to move and be strong will hurt less than a weak, stiff arthritic joint. Again, there's physical therapy, and joint injections are a huge part. Sometimes even shoe inserts can make a big difference. Cast immobilization is kind of classical. I put that on there just for classic reference. And surgical treatments, well, there's a host of them, but the one that we're going to be kind of focusing on in the degenerative world today is hip replacement, because most of the arthroscopy and biologics aren't proven and can actually be shown to actually do harm rather than benefit. So again, briefly, pain relievers, we want to focus mainly on the anti-inflammatory drugs. I believe that a surgical indication in my practice is if you need narcotic level pain relievers to get through your day and anti-inflammatories and Tylenol are no longer working, that is a sign that non-surgical care is failing. In conjunction with joint injections, which is a little outside of the scope of this talk, but briefly, there's several categories. The one that we focus on usually is cortisone injections, and to a lesser extent, the hyaluronic acid injections. And then again, the disease-modifying drugs is more geared towards the inflammatory arthropathies, such as rheumatoid arthritis. Now, when should you consider surgery? Simply when everyday activities are painful and you cannot live your life the way you want to. When you have to modify your life around your pain. When sleep is involved. And other treatments, as I just mentioned, such as therapy and oral medications no longer provide you relief. Or when you're having side effects and harmful results from the non-surgical care that you're taking. And most importantly, you don't have to live in pain if non-surgical treatment fails. There are options out there for you. And this is recently found that over 90% of patients wait too long for joint replacement. And I understand that having an operation is not a little matter. It's not like getting your hair cut. It's a major, major thing to have in your life. But waiting too long and having deconditioning or problems with your health related to inactivity can be just as bad. And this can lead to depression, weight gain. And then if you wait too long and you're in a much more weakened state, it's harder for you to do the rehab, which then can lead to a poorer result when you decide to have surgery. And looking at the United States, all the projection models show that, you are not alone. The upcoming generation here is going to see a huge demand for joint replacement procedures in the United States. Total hip replacement is going to almost double in the next 10 years compared to where it's been the previous 10 years. And this is where the robotics is coming in to try to prevent having these failed surgeries that you may hear about, or dislocation events, or having to have a revision prematurely. So there's a big drive for increasing precision and quality in the United States as far as having surgical outcomes and reducing costs in the long run by not having multiple surgeries and failed attempts to try to get you back to where you want to be. And the economic burden is huge in the United States. Over $60 billion per year is spent in the United States on the treatment of osteoarthritis. And again, here, this is just a graphic representation of how they believe with all the projection models of total knee replacement and total hip replacement are going to go here in the next 10 years. So how many people are having total hip replacement today? Well, approximately 10 million Americans suffer from hip arthritis, and it's the most common cause for hip replacement today in the United States. And as of 2018, more than 300,000 primary, meaning non-revision hip replacements performed in the United States each year. And the trends are only growing. Hip replacement surgery is becoming more and more prevalent because people are living longer. There's an increased prevalence of obesity that we see, and probably most importantly, younger patients are wanting to stay active and maintain their lifestyle in the setting of hip pain. And the good news is you don't have to live through hip pain anymore with the current treatment modalities that we have. So what are the goals of a hip replacement? Why do we want to have a hip or a total hip arthroplasty, as it's called in medical jargon? Well, number one and obvious is we want to relieve pain and get people back to enjoying their life. Some people can have instability from hip arthritis. And on the other side, some people have a severely restricted range of motion or problems even moving their hip secondary to bad arthritis. And some people can have a leg length discrepancy to where your leg actually gets shorter over time as the joint is interrupted and dissolving away, more or less. And more importantly, restoring the offset, which feeds into the biomechanics of how the hip actually works. So in a nutshell, this is just a little cartoon of what a hip replacement actually is. You'll hear terms thrown around of the stem. This is the part of the hip replacement that actually goes inside your thigh bone, or what we call the femur. And this femoral head that you see here now is actually one of the big breakthroughs that we've had in the hip replacement world in the last decade. And the reason why it isn't a nice shiny piece of metal is because we've learned that this ceramic, which is this pink ball that you see there, is actually smoother than metal, and combined with this highly cross-linked polyethylene liner, as it's called, these two advancements in the hip replacement world in the last 10 years have reduced hip wear from where it's almost immeasurable. You need a micrometer at this point to measure how much wear we see coming off of the hip replacement. And then as you heard in Dr. Polstra's talk, the cup, as he called it, this is the cup, as I said, is the part of the hip replacement that goes inside your pelvis in the acetabulum. That is the hole in which the ball on your thigh bone, moves around with, or what we call articulates. So again, you have the acetabular cup that goes in the pelvis, the stem that goes down in the fever, and these two are the articulating components, the ball that moves on the polyethylene liner. And this is a cartoon of what a damaged or very diseased hip arthritic hip looks like. You have total, on an X-ray, you have total loss of the joint space. So the reason why we see a space between the ball and the socket on an X-ray is because cartilage does not show up on an X-ray. So you get the appearance that the bone is floating. When that bone space goes away and the bones are touching, that is what you hear on the street as, quote, bone-on-bone arthritis. And you'll see these osteophytes, or bone spurs as they're called, either on the ball or femoral head, on the acetabulum or the cup socket side, or both. And luckily, we can take a very diseased hip with very precise techniques and replace it and restore, as you see on the right here, a nice smooth round ball articulating with a new socket. And robotics is simply a way to increase the precision and accuracy of placing components to reduce complications that we'll get into. And on a note of what I try to specialize in minimally invasive joint replacement surgery, the traditional joint replacement, if you see this cartoon here, is the posterior approach, which is approximately 8 to 10 inches long, and it goes along the, kind of the back side of your hip joint. The anterior approach, which is on the front side of the hip, is traditionally about 4 inches in length. And it has the benefits, as you see on the right here, of less soft tissue disruption in the form of detaching muscles that control the hip, or disrupting the glute muscles, or gluteus maximus, on the backside of the hip. And it also avoids entering the IT band. And when you are doing an anterior approach versus a traditional approach, you're laying flat on your back, so it is much more accurate to determine leg length and stability checking, the way that I do it, that I'll get into. And I take a modification further on the anterior approach and specialize in the bikini incision anterior hip replacement. So this is an actual, it's hard to even see on this picture. We had to actually move the undergarment to actually see. This is at 1 year from surgery, how the vertical incision, as you saw in the previous cartoon, is changed to match the bikini line, or the natural skin folds of the patient, to try to hide the incision to have a more cosmetic effect. Now, this also does something more than just cosmetics. It's better wound healing, because the body has proteins called collagen in the skin that like to be cut in line with their fibers, not against them. And the traditional anterior approach cuts them perpendicular to those lines, where the bikini goes in line with those fibers. So there's less soft tissue destruction in the skin and the subcutaneous tissue, or the fat layer below the skin. So less wound healing issues and better cosmetics. Now, traditionally, joint replacement, first in its infancy started back in the 50s and 60s. And it began basically with a static plan, which you can equate to kind of holding your thumb up and saying, yeah, it looks pretty good. I think we hit our mark. And that's the way it was for many, many years. And then computers became more and more prevalent in society, and then migrated into the operating room. In the 90s, you started experimenting with navigation systems. And then we combined the navigation into freehand power tools. And then the first robotically assisted total hip replacement was about 10 years ago in October of 2010, which when we first brought robotics into the joint replacement world. Now, you ask, well, why do we care about bringing robotics into surgery of the hip replacement world? Well, if you look at this pie graph of why hip replacements failed, dislocation events were probably about a quarter of the reasons why people would have to have their hip revised. And a dislocation is where the ball leaves the socket and you cannot walk on that. You'll be going to the emergency room, and hopefully it can get put back in place in the emergency room. If not, you may have to go back to the operating room and have it done open with an incision and another surgery. Now, leg length discrepancy was also a huge problem, and that has been, with the increased accuracy and precision of robotics, virtually eliminated. And getting back to my previous mentioning of the ceramic head and the new plastic, the loosening and lysis that you see here, which is the other quarter, that doesn't have to do with robotics. It just has to do with a huge improvement in the quality of the components that we're now putting in. So when we have components that are lasting potentially hundreds of years based on minimal wear pattern, with the precision and accuracy of robotics to put them in correctly, these huge chunks of this pie graph will be eliminated. And again, infection, if you're putting them in a faster, more reproducible way and not having to be open to the environment longer, you can secondarily decrease your infection rate. Same thing with malpositioning problems. Now, the challenges with manual, as you can see, is the dislocation, previous hardware problems. This was actually removed from surgery, where the liner had been in there for several years and already fractured. This was before we came up with a highly crossing polyethylene, and that's because of catastrophic wear, which then leads to a medical jargon term of osteolysis. That is literally where the bone dissolves away from the particles generated from your hip moving, and that secondarily leads to the cup loosening, the stem loosening, or possibly both. Now, risk factors for cup malpositioning, as it's called. There's a sweet spot, if you look at an x-ray, of the angles that we want to put the components in. We want to have, which is probably the most important, related to the pelvis side or the cup, where we want to have the inclination, which is how vertical or horizontal on the x-ray that is standing. You want that to be within 30 to 45 degrees. And most people would agree that 40 is kind of what most surgeons shoot for. And then the anti-version, or how the cup is facing in the front to back direction, of anywhere from 5 to 25 degrees, with the 40-20 is kind of the unspoken rule. And this study here from Massachusetts General Hospital at Harvard saw that this is with well-trained, high-volume surgeons. You hit these marks roughly 50% of the time. So this is where we decide, how can we take hip replacements to the next stage? Well, the Mako is the robotics, similar to the Mazor in the spine world. Mako is the trademark name for the robotics platform that we use in the joint replacement world. It is the only robotics platform to date that is FDA approved for hip replacement. And like I said, that has been started since 2010. So the main function of the robot when it comes to hip replacement surgery is not, I just want to make this clear because it's very easy to get this misunderstanding. It is not something that does the surgery while the surgeon is over in the back corner casually drinking coffee, conversing with the operating room staff. You still have a surgeon that is doing the surgery for you. This is just a tool that the surgeon uses to increase the precision and accuracy of how the hip replacement is performed. A good analogy is, human beings on this planet, as far as mammals are concerned, are the most inefficient mammals to walk this planet when it comes to moving from point A to B. But if you give us a bicycle, we become the most efficient animal to get from point A to B. And that is what robotics provide us in the operating room. They just make it easier to perform highly precise, accurate surgery to decrease the rate of complications. And I utilize the direct anterior approach, but robotics is FDA approved for any way to get to the hip joint, either direct anterior, posterior, or coming from the anterolateral aspect. And again, this is similar to the robotic software that you saw with the Mazor, is we get a CT scan that gets uploaded into the software platform, and we virtually plan your surgery. This is not an actual x-ray of the patient. This is an x-ray that is generated by the software after we have planned it outside of the operating room before going to surgery. So this is what the robotics will provide us after surgery, and to date, it is always spot on. It is amazing how accurate the post-operative or after surgery x-rays look compared to the preoperative plan given to the Mako platform. And the allowed you to have a preoperative plan for what size you are going to use that is extremely accurate. So instead of having to do multiple passes with the preparatory stage, or what we call reaming of the acetabulum, we can now simply say the template says it's going to be a 52 millimeter cup. We're going to use the 52 millimeter reamer and just ream one time. So there's less soft tissue disruption, but having to go in with instruments and tools, multiple passes. And the single stage allows you to have a perfect concentric circle each time. And then after you have prepped it, you can then use the software to precisely, to the single degree of accuracy, set I want to have that 40 degrees of inclination and 20 degrees of antiversion. And simply the robot, you put it in very close, and then the robot will make sure that you are hitting your mark every single time. And what this also does is that for outliers, because that's not only do you want reproducibility with most patients, with surgery, there's some people that I wouldn't say are abnormal, but they have abnormalities with their anatomy that lie outside of what we see most of the time. So that 40-20 rule, we can know that we need to modify this plan based on what we see on the CT scan, because maybe you have just you're very special the way you're born as a patient, when you won't fit that mold of that 40-20 rule, and we can adjust it accordingly based on what we see on the CT scan preoperatively. And that's what we see with the functional implant positioning here on the knee, the hip, and beyond. So why does this matter? Can we prove it? Well, yes. So this is a study that was done comparing manual total hips to robotically, or RTHA, if you see here, total hips done. First 100 cases compared to the last 100 cases of high volume, very, very well-respected trained surgeons as they switched the robotic platform. So as you can see here in the first bubble, if you're aiming here, this is the degrees that I discussed on inclination and inversion. This box is what they were shooting for, and how many lied outside of that in the first one. Compared to the last 100, still they improved significantly, but you can see how many times these high volume surgeons miss their mark compared to robotics, which is much, much more precise in the box here with significant. Now these outliers of note, this again is because they plan to go outside of those 40 degrees of inclination and 20 degrees of antiversion. Because again, with a CT scanning and preoperative planning, sometimes you want to have less antiversion or more antiversion, more inclination on your cup, and you actually plan to do that. And that's why these are not actually outliers from the plan, they're outliers from that 40-20 rule as planned, if that makes sense. And again, comparison of another from Chicago of cup placement. This is outliers, you can see missing the mark, and Dr. Dome is a very, very well respected and high volume surgeon compared to when he switched over, and every single time it would hit its mark. 100% of robotic assisted cups were placed in the quote safe zone compared to the outliers that we see here. And again, this is a preoperative plan that has been perfectly executed each time on cadavers, and with very, very low outlier as far as the degrees that they were shooting for. And how is this market expanding? Well, Mako, as of 2016, was the most recent data I was able to obtain. 23,000 surgeries performed, procedure in 2016 with over a total of 83,000. And virtually now this entire map is now virtually filled in all first world nations when it comes to Mako robotics, and it's only going to expand more and more. Clinical research is ever expanding, and it is all showing the same thing, that robotics, as Dr. Polstra mentioned, are simply the wave of the future. And this is a video I wanted to share of a patient who is now 2 weeks out from a direct anterior hip replacement. So hopefully the audio works.
Hi, I'm coming off 2 weeks after having my hip replaced, my left hip replaced, and I'm doing great. I have not had no rocker cane at this point, and I'm out in the barn every day, so life is good.
If you can, I'll take a little walk for me to show off how you're doing. And again, this is 2 weeks after having a left hip replacement with a direct anterior approach, robotically assisted. So the most common thing that I hear from patients similar to this one after having a hip replacement is, why did I wait so long, doctor? And as full note, she is actually 2 months from her right hip and 2 weeks from her left hip. So I did both hips in her in a staged fashion, and she was at 2 weeks already back in the barn and working with her horses. So in summary, joint pain strikes millions of patients every year. Most delay treatment, and luckily, to be living in this day and age, it is probably the best time in history to be considering a hip replacement, given the advances in components as far as how they are machined and manufactured, combined with the advances that we're making in putting them in correctly. So I'd like to say thank you for all of your attention. And again, we will open up for questions at this time.
Thank you, Dr. Cagle. We actually have a few questions already. So number one question is, how long does a robotic procedure take compared to traditional hip replacement surgery?
So it's a great question. So when I first started using the robotics, it did slow down a little bit, and that's simply because when you do traditional hip replacement with an anterior approach, you use an X-ray during surgery. So I didn't want to just dive straight in and just blindly believe everyone. I still had to prove it to myself. So when I first started, it took a little longer because I would still get the confirmatory X-ray and surgery and kind of prove it to myself. Now I no longer use fluoroscopy, as it's called, during surgery, and I would say it's about equal, because the process of hooking up the robot is very similar to what you saw with Polster. We have to implant for a temporary time frame during surgery and what's called an RF array, so that way the robot knows where you are in space. That does take some time, and then we have to map out the acetabulum and the femur, basically your bony anatomy for surgery. But this time is then made up by having to do less prep work, as we said, as the acetabular reaming is concerned. So we can save time on that step. So it's about the same for most cases. Again, usually the variability you see in surgical time frame is that some patients just have harder anatomy than others. So the robot doesn't speed or slow you down per se, at least in my hands. I would say it's pretty much equal. You spend some time early on in the case to do the setup of the robot and make sure that the robot knows where you are, but then you make that time up later on in the case. But some people it takes 45 minutes to do a hip replacement. Other people it take an hour and a half. Typically the people that are harder are the ones that are more muscular or very, very active patients. Or if you have a lot of patient to love, if there is some added fluff, as I call it, where there's just more soft tissue in the way. But if you, over time, get your technique down with robotics, it does not take any extra time to perform that. And if you look at putting the cup in correctly and not having to go back and redo it, saves time in the long run over many, many patients, because you're just more accurate in positioning.
Thank you, Dr. Cagle. One more question. Can you do bilateral hip procedures using the robot?
Yes, you can, definitely. So robotics, like I said, for me, doesn't drastically alter my workflow. It's very innocuous and out of the way. It doesn't provide any hindrance to doing both surgery. What I would caution patients on with having bilateral hip replacements done is it's more of, are you a good candidate for having both hip replacements done at the same time? Because it is more risky. If you look at all the studies, bilateral hip replacements have more complications than doing it in a staged fashion, simply because you're under anesthesia longer, is more trauma to the body. Because surgery, as good as we are with the minimally invasive techniques, surgery is still a traumatic event to the body. We have to take a knife, make an incision, do a dissection down to the bone, and do our work, and then repair that work with dissolvable sutures. So if you're going to be under anesthesia long with 2 times the amount of trauma to the body, you're going to have more of an inflammatory response, which then leads to a greater risk of infection, greater risk of a blood transfusion, greater risk of a blood clot, or what you call a DVT or PE. Now, in my hands, I've been very fortunate. I haven't had any of my primary joints dislocate using the robotics. I haven't had any of my primary joints get a DVT or infection utilizing robotics. And for full disclosure, I usually try to talk patients away from having bilateral hip replacement surgery unless they are just a perfect candidate, meaning you have little to no comorbidities, as we call them, such as diabetes or high blood pressure, anything that would increase your risk of just being under anesthesia longer. So the robotics doesn't preclude you from having bilateral hip replacements. What precludes you from having bilateral hip replacements is if you're a healthy enough candidate that could handle having both hips rehabbed at the same time.
Thank you, Dr. Cagle. One more question.
Mhm.
Is this procedure done at the hospital as inpatient or surgery center as outpatient surgery?
Both. So, that's an interesting question, because it is still with Medicare. Medicare insurance basically drives the tone for the private pay insurance, and now as of January of this year, the total hip replacement just got coded with Medicare as an outpatient procedure. However, they do not have an outpatient code for a surgery center with Medicare. So if you have Medicare insurance, you're not a candidate to have this done at a surgery center. Okay, that doesn't mean you can't have an outpatient surgery at the hospital. We can still do. I would say that I try to schedule my operating room schedule for patients to go first that are interested in going home same day, because at the hospital we do just as good of same day discharge as we do at the surgery center. The key is you just have to have enough time to be, quote, medically cleared to go home. Now, what does that involve? So basically, it means you have to be eating, you have to be drinking, you have to go to the bathroom as far as urination. You don't have to have a bowel movement, but if you're not peeing, you're not medically stable to go home. And last, but certainly not least, you have to pass your physical therapy evaluation. And the big checkbox for that is you have to be able to go up and down several stairs. So if you're a healthy candidate interested in going home at same day, we try to schedule to be the first case of the day. That way you have enough time to let the anesthesia wear off from your system and eat, have some lunch, and then work with therapy in the afternoon. And then typically you're discharged by 5 o'clock p.m. So you can still have an outpatient surgery at the hospital with Medicare. Now, that being said, we do outpatient total hip replacement at the surgery center if you have commercial insurance that is not Medicare. It's a long answer I hope that clarifies the question.
Thank you, Dr. Cagle. One last question. I guess we have some guests from Rhode Island and they're wondering if you can travel.
So yes, that's an excellent question. So traveling isn't going to harm the titanium and the ceramic and the plastic that we use with surgery. The reason we always worry about traveling after having a joint replacement is because of the blood clot or the DVT/PE risk. Okay. Every one of us today has a risk of a DVT or PE. It's just for most people that is extremely low. But I'm sure you've heard or know someone, seen it on television, whatnot, of a patient who didn't have surgery, had a long flight from New York to Los Angeles, and then got off the plane and had a bad blood clot, as they're called in lay terms, and had a very bad outcome from that. So that is the problem with joint replacement, is that the traumatic event of a joint replacement does increase your risk for a DVT or a PE. And traveling in the first 6 weeks after surgery also increases your risk. So that being said, I try to dissuade my patients from traveling in the first 6 weeks. I tell them, in the absence of a family emergency or some event that you cannot get out of, try to avoid traveling. But if you have to do it, if it's unavoidable, it's not like you're going to break the hip replacement by traveling. You just have to follow some simple guidelines that, to date, I've been very fortunate, hasn't let me down as far as a patient of mine having a bad blood clot on a long car ride or a plane. And that's simple. Every hour you have to get up and move. So that's simply, on the plane, you're going to be taking a walk up and down the aisle for a few minutes and then sitting back down. And you have to repeat that every hour simply to keep your blood from getting stagnant in your legs. So again, I would try to avoid having a hip replacement around a known travel pattern. But if you have to do it, you can. It just increases your risk for a blood clot, if that answers your question.
Thank you. Those were all the questions we've got. I wanted to thank everyone once again for joining us today. We hope you enjoyed our webinar. Again, the recording of the webinar will be available on our website under news section within a few days. If you have any additional questions, please email us at marketing@orthonorcal.com or call 408-412-8100 extension 8158. Have a great afternoon, everyone, and thanks.
Thank you.
Thanks, everyone. Have a great night.
Yep. Stay safe, everybody.